Hello class, welcome to our lecture on the urinary system. These are our objectives for the lecture. If you are comfortable with these, you should do very well on the quiz, as always. So we are going to look at the urinary system, which is the kidneys, the ureters, the bladder, the urethra, its functions, and some common pathophysiology. So the function of the urinary system is to get rid of metabolic waste. And by metabolic waste, we mean this is stuff that's made when you are breaking down food, especially when you are breaking down protein, as well as getting rid of excess water. The urinary system obviously forms and then gets rid of urine. And in doing so, it plays a big role in regulating the fluid in your body. How much fluid you have, what is its pH? Your main pH control in your body is the kidneys. So this plays a huge role then in homeostasis of a lot of your body, but generally speaking of your body fluid. Again, how much do you have and how acidic or basic is it? The kidneys make erythropoietin, which you may remember from the lecture on the blood. Erythropoietin is the hormone that triggers blood cell production. And it also produces a hormone called renin. Renin works in concert with angiotensin and aldosterone to help control your blood pressure in your body. A quick overview of the urinary system, particularly in the pelvis, before we go any further. In the male urinary system, both the urinary system and the reproductive system share the same plumbing, if you will. And you often hear this referred to as the male genitourinary system. In the female reproductive system, both the urinary system and the reproductive system, we don't got that. The ductwork, if you will, for the urinary system is the urethra. The ductwork for the reproductive system is the vagina. It does not share the same tube. Just so we're okay with that, because I didn't discuss that with the very first class I ever had, and they had terrible, terrible discovery when they got to their back office stuff. If you are not sure what I'm talking about here, come find me during office hours. We can go over it a little more in detail. So the urinary system is made up of two kidneys, which are these guys up here, about the size of your fist. They sit fairly high on your lumbar vertebrae, high in your back, higher than most people think. The kidneys are drained by two ureters, which are these tubes right here, going down to the bladder. Do not confuse ureter and urethra. I promise you will see these on the quiz. It's very easy to mess the two of them up. The ureters drain the kidneys, and you have two of them because you have two kidneys. The ureters drain to the urinary bladder, which sits very low in the pelvis. And then the urinary bladder is drained by the urethra. Again, make sure you are comfortable with ureter versus urethra. The kidneys sit behind the peritoneum in the upper lumbar region of the vertebrae. The peritoneum is a membrane that covers the inside of the abdomen. It sits over the kidneys. So the kidneys are, you'll hear them called sometimes retroperitoneal. Retro means behind. So that just means the kidneys sit behind the peritoneum. On top of the kidneys, we find the adrenal glands. We'll talk about these when we get to the endocrine system. The kidneys, if you were to cut something open to look at its kidneys, you wouldn't actually see the kidneys. What you would find is two great big clumps of fat sitting on the back of the body. And that's because the kidneys are covered in fat because the kidneys are the most metabolic organ in the body. They use tons of energy to filter out waste from your urine or waste from your blood to make urine and to make sure that everything that needs to be in your urine is there. There's connective tissue that also covers the kidney, that holds it in place and supports it. If we were to cut a kidney open, we'd see it has two distinct regions. The outer region is called the renal cortex. The inner region is called the medulla. Here we can see a nice example of what I'm talking about by cortex and medulla. So you can kind of see this sort of line running between the outside and the inside of the kidney. Along there, more or less. This outer part that we see is the cortex. It's kind of lighter in color. And then the darker in color in the middle is the medulla. And that's what we sort of see in this drawing right here. You can see the lighter cortex on the outside, the darker medulla on the inside. Some other things of note to point out with our gross anatomy of the kidney. The ureter, you can see, draining urine from the kidney down to the bladder. The upper enlarged part of the ureter, and of this part right in here behind the artery and the vein, is called the renal pelvis. A pelvis just refers to an opening. So by renal pelvis, they mean the large opening in the ureter that we find up by the top of the kidney. Up towards the top of the renal pelvis, you find these little calyces. These are at the tips of the little pyramids right here. And that's just what we mean by a calyx. This little area of the renal pelvis that sits right underneath the triangles up here, the pyramids. Now, like I said, cortex and medulla, if we look more closely at a little blown up version right here, we see within the cortex, we find these little round guys right here. These are called glomeruli, singular is glomerulus. This is the filter by which we get all of the waste product out of your blood. We'll look a little more in detail at how that happens. And then down within the medulla, we find this long twisted tubule. This tubule helps us to concentrate urine, to pull as much water out of it as possible so that we don't lose any more water than we need to. It also helps with making sure any good stuff that we filtered out of the blood, like nutrients or electrolytes, gets put back into the blood. Some combining forms that talk about the kidney, both reno and nephro refer to the kidney. Reno is Latin, nephro is Greek. Glomerulo, obviously referring to a glomerulus. Pyelo refers to that renal pelvis. Do not confuse pyelo with pyo, which you've probably seen before, because pyo refers to pus. And then anything with cali, C-A-L-I, is talking about one of those calyces. Obviously, anything with UR, is referring to urine or the urinary tract or something related to it. So you see both uro and urino. Again, be very careful about ureter versus urethra. I have so many students who miss those. And then just like we had two terms for the kidney, we also have two terms that refer to the urinary bladder, both cyst and vesic. Cyst we've seen before. Cyst, usually when my students think of a cyst, they think of the combining form cyst, they just think of, a cyst. You have to go to the doctor and have it removed. But cyst just refers to a bladder in general. Remember, you have two cysts. You have a cholecyst, which was your gallbladder. You also have a urocyst, which is your urinary bladder. So right now when we're talking about cyst, we're talking about the urinary bladder. The nephron is the working unit, the functional unit of the kidney. This is where all the magic happens. It's a tiny little tube with a bunch of different parts to it that we'll look at in a little bit. The very front of the tube is called the glomerulus or Bowman's capsule. This is the filter. Blood will enter the glomerulus and all the waste products, most of the fluid in the blood will be filtered out into the tubule. From there, the tubule has these twists and turns that allow it to filter, allow it to determine what it wants to keep in the urine. It's wrapped around very tightly with blood vessels that will reabsorb stuff that we don't want to lose in urine. and it will pull stuff out of the blood vessels that we do want to put into the urine. So here's our nephron right here. You can see this is our tiny little arteriole that's coming off of the renal artery right here, bringing blood into the glomerulus. That's the filter. That's where all of this starts. And then that blood leaves the glomerulus, that little artery right there, and it wraps around the tubule that you can see here, because that's going to reabsorb stuff that we want to keep out of the urine, and you're also going to put more waste product into the urine if it didn't go in through the filter. After the glomerulus, blood will travel down this little proximal convoluted tubule right here. It goes down into the loop of Henle. The loop of Henle plays a big role in concentrating the urine, making sure that we pull as much water as possible out of the urine so that you don't get dehydrated. And then it'll go through this distal loop of Henle, ultimately into this collecting duct that's draining from a bunch of other nephrons, and that's draining to the calyx. And then that calyx will drain to the renal pyramid, or to the renal pelvis, sorry. Blood supply to the kidney. Blood goes into the kidney through the renal artery. If this is blood that's entering the kidney, is it clean or does it need to be cleaned out? This is blood that needs to be cleaned out. This is blood that's dirty. It goes to the glomerulus and then circulates through the glomerulus and then circulates around the tubule, reabsorbing water out of the urine. Blood leaves the kidney through a bunch of tiny little venules that will eventually become the renal vein, and it dumps into the inferior vena cava. If you remember from the cardiovascular system lecture, we looked at an aneurysm that was down near the kidneys. We looked at, here's the aorta here, here's kidney 1, here's kidney 2. This is why I'm in science, not art. And you had the renal artery coming off here, and then you had this great big aneurysm down right below that. That's a very common place to find an aortic aneurysm. That's your aorta. Because there's a lot of turbulence in this area right here, because you have blood that's going straight down, you have blood that's going off to one side or the other. So it's not uncommon to see aneurysms right around that area where the aorta bifurcates into your renal arteries. The majority of your urine is water, 95% of it's water. And then a very, very small percent is all kinds of stuff. You see things like urea, uric acid, creatinine. Creatinine I mentioned in the musculoskeletal lecture. This is a waste product that's just made from using your muscles. You're always releasing a little bit of creatinine from your muscles throughout the day. And measuring how much creatinine is in your urine is a good way of determining how your kidneys are functioning, if they're working properly, because you should always see a fairly level amount of creatinine in your urine. You see electrolytes in the urine. This would be things like sodium, potassium, calcium, chloride, magnesium, all the stuff that you get from drinking the Gatorade bottle. Pigment, most of which comes from urea. And urea is the main waste product, the main waste material in urine. It's a byproduct of protein metabolism. It has nitrogen in it. You release nitrogen as you break down protein, and that nitrogen is converted to urea and then released through the kidneys. The study of urine is called urinalysis. You guys, when you get to back office type stuff, will learn how to do urinalysis, doing urinalysis with the little dip strip, or even learning how to plate urine if you needed to do a culture on it for any reason. So there are 3 steps to turning blood into urine, to filtering the stuff out of blood that we don't want to keep and turning it into urine. And I like to liken this to cleaning out your closet, which is probably something most of us can relate to because we've all been stuck at home trying to Marie Kondo the daylights out of our houses. So the first step to cleaning out your closet, it's spring, you don't need all those sweaters in there anymore from the winter, time to put those away, time to break out the summer stuff. So the first thing you do, you just open the closet door, grab everything that's in the closet and throw it on your bed. Here we go, time to sort through all of that. That's the first step of urine formation, filtration. Blood pressure in the glomerulus forces just about everything in your blood. So this would be stuff like water, electrolytes, nutrients, even toxins, stuff you do and don't want, forces it through the glomerular wall into the nephron. What we have left at the end, like in this tiny little arteriole right here, this is some pretty sludgy stuff, mostly cells and some proteins. Think coffee grounds. This is very, very sludgy. We've lost all of our water because the water's all in the nephron. So stuff that you see leaving the blood and going into the nephron, water, which obviously we want back. Also electrolytes, we need those. Some soluble waste, this would be stuff like urea, for example. Nutrients, we definitely want those back as well. And then toxins. This could be anything like drug byproducts or drug breakdown. It could be stuff that's further made by breaking down nutrients, all sorts of things that would count as toxins. So the second step then, think about all of your clothes sitting on your bed. Now you're going to sort those all through. You're going to figure out, what do I want to keep? The rest of it, gets stuck in a pile that you'll eventually take to Goodwill someday. And that's the second step of urine formation, is reabsorption. We're going to figure out, what do we want to keep out of that urine and put it back in the blood. So this would be stuff like almost all of the water in our urine in the tubule is going to be put back into the blood. Almost all of the electrolytes in the tubule, almost all of the nutrients, because we want to keep those. Those are very, very important. If we lose all of our fluid, all of our water through our urine, we'll dehydrate very quickly. If we lose all of our electrolytes, we'll have issues with nerve and muscle function. If you lose all your nutrients, you will be very, very malnourished. So we're taking all of the stuff we want to keep, putting it back into the blood, leaving the stuff that we don't want behind in the tubule. The same way that you're going to put all the clothes you want to keep back in your closet and leave the clothes that you don't want to keep on your bed to go to the Goodwill. So the last step then to urine formation is secretion. And if we're sticking with our analogy of you cleaning out your closet, I suppose this is you dragging all of your crap out to the car to then drive it to Goodwill. In secretion, we are pulling stuff out of the blood into the tubule. This is stuff like waste products, toxins, drug metabolites, both drugs and drugs. The drugs you get from your pharmacist and the drugs that you might get at Colfax and Federal. Not that any of you would know, I'm sure. This requires energy. Remember when I said earlier, the kidney is the most metabolic organ in the body? This is the part where we burn all of that energy, because a lot of this stuff up here, this doesn't want to leave the blood. So we have to use ATP to force it from the blood into the tubule. And this takes place mostly along this distal convoluted tubule, this part right here. Now the fluid that we have left behind, now that we're done with step 3, this is urine. And we can further concentrate it in the distal tubule, and we can further concentrate it as it's going from the collecting duct down to the calyx using antidiuretic hormone. This is a hormone that comes from the pituitary, also called, it has two names, antidiuretic hormone, or ADH, or also called vasopressin. We'll talk a little bit about that when we get to the endocrine system. So from the kidney then, or from the calyx, urine will drain to the renal pelvis, which remember is the upper enlarged part of the ureter, and then goes from the ureter to the urinary bladder, is stored in the bladder before release. The urethra, remember I told you make sure that you have ureter and urethra straight. The urethra drains the bladder. It empties when the muscle of the bladder contracts. The muscle of the bladder is what kind? Which of our 3 muscle types? Think back to many weeks ago. The muscle of the bladder is smooth muscle. Involuntary, you have no control over it. There are two sphincters in the urethra that regulate urination, the release of urine. You have one that's internal and one that's external. The internal or upper urinary sphincter, they have two names, is involuntary. This is the sphincter that causes that gotta go to the bathroom feeling. The lower one is the one that you can control, lower or external. This is the one that you teach your dog or your 3-year-old how to use so they don't pee all over the house. Some key terms here. These will be very helpful as you're going through your homework and preparing for the quiz. So let's talk about some pathology then, common diseases that you see of the urinary system. We'll talk about UTIs, infections, kidney failure, kidney stones, some cancers. As you get older, everything slows down, and your urinary system is no exception. You lose the ability to concentrate urine in the kidneys, which means you're going to lose more water in your urine, which means you're going to need to drink more water, which means you're going to be peeing a lot more even at night. And because of this, you'll often see older patients don't drink as much water as they should because they're tired of getting up 3 times a night to go to the bathroom, understandably. You also see a greater susceptibility to urinary tract infections. They happen more frequently. In men, the prostate can get enlarged. This is very natural and seen in just about all men. And then the bladder is not able to hold as much, and the muscle of the bladder gets a little weaker. So you wind up with issues of incontinence, involuntary leakage of urine. UTIs generally occur when a pathogen enters the bladder through the urethra. It travels up the urethra and then causes cystitis or inflammation of the bladder. The pathogen in question is usually E. coli, and E. coli is found in one place in the body. Normally it's found in one place in the body. It's found in the large intestine. So this happens when you get bacteria from feces that is introduced to the urethra, and then that bacteria travels up the urethra and produces an inflammation of the bladder. This is why they say when you're potty training little girls, you teach them to wipe from front to back so they don't introduce colonic bacteria into the bladder. UTIs are much more common in women for a couple of reasons. One, the urethra is a lot smaller or a lot shorter. In men, the urethra is about 8 inches. In women, the urethra is about 1.5 inches. That's much shorter distance if you are a tiny little E. coli bacteria to have to climb than to go a full 8 inches. The other reason why you see UTIs more often in women, the urethra is just closer to the rectum than men. So it's easier to introduce bacteria to the urethra. Pyelonephritis is inflammation of the kidney and of the renal pelvis. Signs that you'll see of that: dysuria, so our prefix dys here, hopefully you remember, means painful. So painful urination. Bacteriuria would mean what? Bacteria in the urine. And then pyuria, what is pyo? Pyo is pus. So painful urination with presence of both bacteria and pus would be your sign of pyelonephritis. Urethritis is inflammation of the urethra. Generally speaking, you see this in men. Remember, because men have the combined genitourinary system and share that same ductwork for both the reproductive and the urinary system. Usually you see this with sexually transmitted diseases, chlamydia, syphilis, gonorrhea, things like that. Glomerulonephritis is inflammation in the kidney, specifically inflammation of the glomerulus, of that little filter in the kidney. And often you see this after your patient has had a really bad infection somewhere else. They've had maybe a really nasty viral infection. And what you see here is the glomerulus doesn't filter quite like it should. So you get hypertension and edema because you're starting to retain water. Your patient, because they're retaining water, will have oliguria. They're not producing a lot of urine. This patient will need to go on to dialysis to address this issue with the glomerulus until it's working properly. When you see glomerulonephritis, often you'll see hematuria and proteinuria. You'll see loss of blood and loss of proteins in the urine. This can be, if it's not caught and treated right away, can lead to some really nasty renal failure, renal disease, possibly having to go onto a kidney transplant list. And you'll also see uremia, which is buildup of waste products in the blood. And those waste products, if they reach high enough quantities, will be toxic to your patient. So again, your patient needs to go on dialysis. Nephrotic syndrome is kind of similar. It happens when the glomeruli start to filter out proteins. Proteins should not be in the urine. Proteins should stay in the blood where they belong. So you will see these two contrasting signs here. You'll see proteinuria, which is protein in the urine. And then you'll also see hypoproteinemia. So hypo means lower or less or below. And then emia refers to something in the blood. So you see here presence of protein in the urine, low protein levels in the blood, because all of these proteins that should be in the blood have traveled over to the urine or being urinated out. Because of this, you'll see issues with edema. Your patient won't balance water properly, and you'll see these lipoproteins that the liver will release to make up for the low protein levels that you already have in the blood. You'll be able to detect that in a blood sample. Acute renal failure happens when your patient's kidneys just suddenly go into failure. There are a few things that can cause this injury to the kidneys. Maybe they were in a really bad car accident and they got hit on the back and that damaged the kidneys. If you go through shock, there are some toxins, very bad infections of the kidneys that can lead to acute renal failure. This is going to lead to dialysis, and if this does not turn around, probably your patient's going to need to go on a list for a kidney transplant. Okay, what is dialysis? We talked about that a lot so far. There are two ways that you can do dialysis. Essentially, what you're doing in dialysis is taking your patient's blood out and filtering it for them. You are their kidney. Hemodialysis is the one that we most commonly think of. Blood is going to go over a membrane. You have a big port in your patient's arm that you hook them up to the machine with. That machine pulls blood out of the patient, passes it over a membrane to clean out any toxins, and then returns that cleaned blood to their body. This can take a while. This can take several hours, and usually your patient who's on dialysis will have to do it several times a week, 3, maybe 4 times a week, depending on how severe their kidney failure is. The other form of dialysis we have is peritoneal dialysis, where you introduce fluid into the peritoneum, and that fluid absorbs those waste products, and then you remove that fluid and replace it with new clean fluid. I think between the two of them, hemodialysis is a little more effective, but usually patients will have a choice which type of dialysis they would prefer. Urinary stones are also called urinary lithiasis. This combining form here, litho, just refers to a stone. We see stones in the gallbladder as well, choleliths. Usually these are made from some kind of calcium salt that builds up on the inside of the kidney. And you can see these if your patient is very badly dehydrated. Sometimes you'll see these with an infection. If there's some kind of weird pH, either of the urine or of the blood. Urinary stasis, so the urine is not moving through the kidney. There's a blockage somewhere. Metabolic imbalances, some toxins will cause this, where you get this buildup of calcium salts in the blood, and then those calcium salts are filtered out through the kidney, and that high level of calcium salts in the kidney then leads to formation of kidney stones. The toxin that's best known for this actually is ethylene glycol, which is the active ingredient in antifreeze. Antifreeze will do a number on your kidneys if you drink it. As these calcium salts, as these calculi or these rocks start to move through the urinary tract from the kidney down to the bladder, it's incredibly painful. Generally speaking, if you talk to people who have both passed a kidney stone and had a baby, they'll tell you that passing the kidney stone was much less pleasant, which makes sense because the urinary tract is not designed to have a rock up in it. The issue with kidney stones, besides your patient probably wanting to die, is that they can block the ureter or block the kidney, and then you can see infection or hydronephrosis, which is buildup of water, buildup of fluid in the kidney, and the kidney will get very enlarged. So how do we get that rock out of there? Sometimes it'll come out on its own if it's small enough. You may have to go in surgically and pull it out. You can do lithotripsy. Tripsy, our suffix tripsy here, means crush or cut, surgical crushing or cutting. To do extracorporeal shockwave, you get a very high power ultrasound and you put it on the back over the kidneys, and that vibration will help to actually break up those stones into very small pieces that are easier to pass. You may have to do an endoscopy, go up with a camera into the ureter or into the bladder and crush that kidney stone and then pull the bits of it out. Either way, your patient's not going to have a good time. So these are some pictures of kidney stones. This one right here, you see for comparison size. This is an electron microscope of our kidney stone over here. Look at all those sharp pointy ends. You can imagine now why these are so very, very painful. Kidney stones show up really well on CTs and MRIs and radiographs because they're nothing but minerals, and minerals are made for that. You can see in this picture up here, our patient's got several there, a couple up here, one over here, a few down here. They're definitely not having fun. Here's a fairly large one there. Big old kidney stone up here. I like this one because if you look at the renal pelvis and the ureter, if you turn your head sideways, it looks like a dinosaur. One of my students pointed that out to me, and now I can't unsee it. Kidney cancer is a very specific type of cancer that's usually linked to certain exposures. Exposures to really high industrial chemicals, high potency chemicals. Cadmium is a heavy metal, herbicides, pesticides. Schistosomiasis is a parasite that lives in water. We don't have it in the US. But there are a lot of places where it's very common. Sub-Saharan Africa, Southeast Asia, China, all have high levels of schistosomiasis. It reproduces in your bladder, and then the eggs are passed out through urine. If you have repeat levels or repeat infections of schistosomiasis, that increases your risk of kidney cancer. Cigarette smoking, of course, this is not good for anybody. If you have high blood pressure, like chronically high blood pressure, that will affect the kidneys. And then if you've ever gone into kidney failure, that increases your risk of having kidney cancer. Your key symptom of kidney cancer is all of a sudden you're peeing out blood. Hopefully that would be enough to scare anybody and send them into the doctor. Treatment depends on how big the tumor is. You can do just a partial nephrectomy, where you take part of the kidney out, you take the tumor and leave the rest of the kidney, or you may have to do a complete nephrectomy and remove the whole kidney. If you do remove the kidney, that's okay. You can still get by with one. The other kidney will enlarge a little bit to work harder and make up for having to work by itself, but you should be okay. And then, of course, our classic chemotherapy and radiation. If you catch kidney cancer early enough, you generally have a very good 5-year survival rate if that cancer hasn't spread through the body. Bladder cancer shows similar symptoms and similar risk factors. Again, you'll see this sudden blood in the urine. Sometimes you'll see pelvic pain, frequent urination as well, almost like UTI type symptoms. Risk factors for bladder cancer, again, smoking. Again, pesticide exposure, some radiations will do that as well. Schistosomiasis. If you can see a family history towards bladder cancer, you see a family history towards lots of different cancers. And then if you have had just lots and lots of UTIs, lots of bladder infections over your life, that increases your risk of bladder cancer. Diagnosis for bladder cancer varies. Usually they'll start with cytology. So take a urine sample and look at it under a microscope and see what kind of cells are coming out in that urine. And if those cells look cancerous, then we'll do a cystoscopy, which is a camera up the urethra into the bladder. I have talked with a friend who had one done. It is not a pleasant experience. And while you have that camera up in the bladder, you'll usually do a biopsy of the tumor. So take a small piece of it, send it to pathology, have them take a look at it and tell you what's going on. Treatment for bladder cancer varies. Obviously, you'll need some kind of surgery. If it's a very small tumor, you may be able to just remove the tumor. If it's bigger than that, though, you're probably going to have to take out the whole urinary bladder. And then, of course, chemo, radiation are classic cancer treatments. If the cancer hasn't spread, metastasized, you have a very, very good 5-year survival rate. So what do we do when we pull out somebody's bladder? Because that urine's got to go somewhere. We have two options when you have to remove the bladder. One, you can make a little neobladder. So you take this small portion of the small intestine here, and you kind of set it up to make sort of a new fake little bladder. That's what we see right here. You drain the ureters down into the intestine, hook it up to the urethra. It's not going to function quite the same as a normal bladder. It's not going to expand quite as well, but it does the job. It's a very nice alternative. Your other alternative, if you had to remove the bladder and the ureter, would be, again, to take a little bit of the small intestine and you're going to hook it up so that you have a little ostomy right here. So your patient will be hooked up to a bag. The ureters will drain into that little bit of the small intestine, and then the urine will drain out into a bag. The other option that I don't think is done very frequently is to just drain the ureter straight into the small intestine, or straight into the small intestine, and then just have the urine processed out with feces. Urinalysis is a very, very common diagnostic tool. You guys will learn how to do it when you get to your back office stuff for medical or vet. You take your urine sample, you have a little strip, what we see here, a little strip of paper with a bunch of little squares on it, and you dunk it into your urine sample, and then you time it. And after 30 seconds go by, you read the very first strip at the bottom to test for glucose, and then you read bilirubin as well. Then you wait another 10 seconds and you read for ketones, and on up the strip. If you've ever had a fish tank or an aquarium and you've had to test the water in the fish tank for stuff like ammonia or pH or nitrates, it's very similar to that. When you're doing urinalysis, you'll be checking for things like color. The urine should be kind of straw colored. It shouldn't be dark. If it has blood in it, that's a bad sign. Turbidity is just how cloudy it is. Should be clear. If it's cloudy, that might be a sign that your patient is developing crystals in the urine. That could be a sign they might start throwing kidney stones. Specific gravity measures how quickly sediment falls to the bottom of the urine. pH obviously is how acidic or basic the urine is. The urine should be a little acidic, pH of about 5. And then chemical components are a lot of this stuff right here: nitrate, uro, bilirubin, protein, ketones, bilirubin, glucose. That's what they mean by chemical components. And then cells, crystals, or casts are crystal molds of the inside of the tubule, little tiny microscopic crystals that, again, would be a sign your patient's probably at high risk for developing kidney stones. Urinalysis is also the way that we do pregnancy test. If you have ever peed on the stick for the pregnancy test, that is an example of urinalysis. You're testing for presence of human chorionic gonadotropin in the urine. Urine culture is another very common technique with urine testing. You do this to identify pathogens, to see what kind of bacteria or virus or parasite is causing an infection. You do this a lot of the times with UTIs. You'll do it sometimes with a kidney infection. This is a common way of testing for sexually transmitted diseases as well. So you will take a clean plate, imagine this plate but with no little white dots on it, and you will take a little tube full of urine and you'll stick a cotton swab in the urine, and then you'll rub that urine all over the plate. You'll tape it up, stick it in an incubator for 24 hours, and then you'll come back to something like this with all these little dots all over it. You'll sample the dots and see what kind of bacteria you have in there, or virus, or parasite. And then from there, that will give you an idea what infection you're dealing with, how to treat it, what medications will work well, etc. So a bunch of key terms here at the very end of the slides. As always, I would look over those on your own time because these will be very helpful for the homework and for prepping for the test. And if you have any questions or want to go over anything further, please stop by office hours. I'd love to see you.